All right, so you might notice this is the wrong title. I've added a little bit of some of our other research because I thought it might be of interest to you today. So I've included non-surgical management of ACL injury more broadly, as well as addressing healing of ACL rupture. You might see I'm from Melbourne in Australia. I think we're around about just past midnight, so that's the time zone I'm on, just to let you know. No excuses, but it's all good. So there's around about 2 million ACL ruptures that occur globally per year. And the issue with this is that on average, ACL ruptures are associated with poor long-term outcomes. For example, by 2 years, around 50% of people are dissatisfied with their knee function, and that's irrespective of undergoing ACL reconstruction or undergoing management with rehabilitation alone. And we also know, of interest to a lot of people in the room, is that 50% of people or more develop radiographic osteoarthritis within just 10 years of injury. So ACLs are most common in young adults and adolescents. So we're talking about people in their mid-20s living with osteoarthritis. And this is what this looks like. So this is actually a photo of my own knee after I woke up from ACL reconstruction revision surgery, so after I tore my graft. I then went on to re-tear this graft as well. And this is an MRI of my knee aged 30 years. And you can see it looks pretty awful with some signs of moderate to severe osteoarthritis in the knee. So unfortunately, this is not an uncommon experience. In fact, my population, who was a young soccer player who returned to sport, 1 in 3 people go on to rupture their graft in that population that I was in. And the majority of those go on to develop osteoarthritis that they'll live with for the rest of their life. So we really need more effective strategies to improve long-term outcomes for people with ACL injury. So there's 2 main treatment options. So ACL healing aside, there's early ACL reconstruction or management with rehabilitation alone before considering whether ACL surgery is likely to be of benefit. So there's a number of systematic reviews and 2 high-quality RCTs showing similar outcomes on average between treatment strategies. So the RCTs found that early reconstruction is of no additional benefit than initial rehabilitation. And when you perform rehab first, around 50% of people do not require surgery, with no difference in outcomes at 2 years, 5 years, and 11-year follow-up. However, in a slightly different population, so this isn't people with acute ACL rupture, now we're talking about people with persistent knee instability for months or years after ACL rupture that have not undergone any previous rehabilitation. So in this group, ACL surgery was found to be more effective than rehabilitation alone. This is within the NHS in England. So based on the existing evidence, it's now recommended that in most cases, people trial rehabilitation as a first-line treatment before considering an ACL reconstruction. However, certainly where I live in Australia, this is not the case. So around 90% of people in Australia undergo reconstruction. Based on a few conversations I've had with people in the room, it sounds like it may even be more than 90% in Poland who are typically treated with ACL surgery. And the rate of surgery is increasing and has been increasing incrementally for the past few decades. So why is there this really high rate of surgery that doesn't align with the best existing evidence? I think we can learn a lesson from looking at the history of ACL injury research. So the earliest publication I could find was in 1895 and the second one in 1917. So back then they reported 2 cases of ACL rupture that were surgically treated. Now one person was kicked by a horse and was severely injured, and the other in a mining accident was buried by a fall of earth and fractured a whole bunch of bones at the same time. So these people had complete disability, couldn't weight bear at all, and they were managed with ACL surgery. So it was noted back then that ACL rupture was really rare. Severe injury hardly ever occurred. But then in 1919 was the commencement of World War I. So now, because of more trauma in military soldiers, ACLs were more frequently recognised. And this surgeon noticed that there was a pattern in which they were identified. So someone would say they sprained their knee, they'd be treated with prolonged immobilisation, typically in a cast, and then some would go on, return to duty, and then have another instability episode or another injury. And only then was ACL rupture diagnosed. So thinking about current practice today, this is someone who would be very suited to ACL surgery. So that's persistent instability. So this surgeon recommended turning up the patella in every doubtful case to reveal an ACL rupture which otherwise would have gone unnoticed and untreated. So come 1935, there were actually 3 differences in opinions amongst surgeons. So some thought the ACL was of no importance whatsoever. Some believed other ligaments will compensate for a ruptured ACL, whereas a third group believed ACL rupture will cause definite disability and must be surgically repaired. It just happened to be that that third group were the people who were publishing the papers because they were the surgeons who were developing new techniques. So the early surgeries were used only for those with severe disability in which surgical repair was the only hope of normal function. But again, this surgeon advocated that surgery can and should be increased to include those with even less disability. So then come 1983 with the first literature review on the topic, they highlighted that it's those with severe functional instability and the relationship with significant traumatic arthritis which has led to more aggressive surgery. And this author advocated that we should be operating on instability and not laxity, and that should be the foundation of treatment in those with chronic knee problems. And he also emphasised that there's little question of the necessity of stabilising a chronically unstable knee. So going back to the RCTs we have available, this actually aligns with what lessons learnt 1983 to the early 1900s. Chronic instability will benefit from surgery, but not everyone requires ACL surgery. So the development of less invasive surgeries, more accurate earlier diagnosis led toward a push towards early surgery for more people, and it was no longer preserved for those with chronic instability. What other contributors may there be to this high rate of surgery? Well, there's common misconceptions which have been prevalent for a number of decades and still exist today. One of which is that surgery is the best treatment if you want to return to sport, especially cutting and pivoting sport. So we've conducted a systematic review and meta-analysis of the existing literature, and we found no difference in return to sport rates, whether you're managed with ACL reconstruction or you're managed with rehabilitation alone. And this was despite the fact those studies there in red actually told people that if they didn't have surgery, they shouldn't return to sport, or they chose people for non-surgical treatment because they didn't want to return to sport. Even despite that bias in the design, there was still no difference in return to sport rates. And not only that, there was also no difference in the level of sport that people returned to. So the level of activity participation assessed with the Tegner. So the next common belief is that you'll have an increased risk of further knee damage if you don't have ACL surgery. So there was a systematic review that looked at this question in 2020 in BJSM that found that this belief wasn't supported by the existing literature. The evidence was too weak. And I published an editorial on this topic in BJSM because I was finding a lot of people are recommending early surgery based on this assumption that it will protect the knee from further damage. And I looked into all the references that had been used to support this belief, and they were all completely inappropriate. So they all used surgeons' records at one point in time where they found that people who present months or years after injury have more meniscus damage than those who present soon after injury. So based on that alone, they thought everyone should be having early surgery. So that's an inappropriate design to answer that research question. And we recently, in 2024, read a new article from a Swedish group on the narcotics prospective cohort study. And this reflects usual care in Sweden, where people were treated with rehab first, then surgery if desired or if deemed appropriate. So 48% of people in this study had surgery within 2 years. And what they found is after ACL reconstruction, there was a higher rate of further knee damage than there was in those who were managed with rehab only. So what about osteoarthritis? For some time, people thought that surgery actually reduces your rate of future osteoarthritis. This is not the case. Certainly when we look at radiographic OA, there's a number of systematic reviews that find a high risk of OA in those surgically treated. So this here is an umbrella systematic review. So that's a systematic review of all existing systematic reviews, which found an increased risk of OA if you're managed with ACL reconstruction compared to rehabilitation alone. Being aware that this is radiographic, it's not symptomatic. We don't have the same evidence for people with knee symptoms and radiographic changes. And we can get some clues into why this might be the case. There's been a number of exploratory studies conducted in the Canoon trial. So here you see an increase in inflammatory cytokines, which have been advocated in the development of osteoarthritis. So they're elevated at 4 months and 8 months after ACL reconstruction compared to rehabilitation alone, but they're still higher at 5 years follow-up in those surgically treated compared to those non-surgically treated. And it's not just inflammatory cytokines, it's the change in bony shape as well. So here you can see more rapid changes in bone curvature in those managed with surgery compared to those managed with rehabilitation. And you can also see more rapid change of bony shape, consistent with early onset osteoarthritic changes in those managed with ACL surgery compared to those managed with rehabilitation. And so what about ACL healing? For decades, it's certainly when I went through physiotherapy school, I was told that ACL ruptures cannot heal. It's intrasynovial, the ends of the ACL get bathed in synovial fluid, and healing is not possible. The very notion of trying to identify copers with rehabilitation implies people coping without an ACL. But is this really the case? I was pretty surprised to see how few studies had actually looked at whether the ACL can heal. Before we published a couple of studies last year, I Googled, can an ACL heal? And got a fairly consistent response. It cannot heal because there's no blood supply. Cannot heal without surgery. And we surveyed 766 Australians with a recent ACL injury, and only 2 out of 10 thought it was possible for an ACL to heal. However, a literature review in 2021 found that all existing evidence did not support the belief that the ACL couldn't restore fibre continuity. They found that this belief was actually outdated, but the existing evidence was of very low quality, and most people included partial ACL tears, which we expect to heal. So it was hard to interpret the findings from the existing studies. So we looked into ACL healing within the Canoon randomised controlled trial. So the Canoon RCT randomised 121 active young adults to either early ACL surgery or initial rehabilitation, and optional delayed surgery if they wanted or if it was needed. So by 2 years follow-up, 50% had that optional delayed surgery. Now, there was no difference in a variety of outcomes at 2, 5, and now 11 years follow-up between the randomised groups, but also no difference between the as-treated groups, delayed surgery, early surgery, or rehab only. So we wanted to go back. They had MRIs from a variety of time points. We wanted to analyse MRIs for signs of ACL healing in those who hadn't had surgery, and go one step further and look at the association between healing and patient-reported outcomes. So there wasn't a lot of guidance on how we should assess healing, but there is an item in the ACL OAS MRI grading system which assesses both continuity of the ACL as well as appearance in terms of thickness and signal. So for this study, we clumped grade 0 to 2 together. So this is a continuous ligament from its origin to its insertion. At baseline, everyone had a discontinuous ligament, a grade 3. But recognising that amongst that there's variability in the quality of the appearance of the ACL. So what did we find? So on 2-year MRI, 30% of people who were initially randomised to rehabilitation first had a continuous ACL on MRI. And you can see a 50-50 split between a normal appearance ACL, as if it was never injured, and a thin or elongated but continuous ligament. So interestingly, when we look at the 3-month MRI, of those who went on to have delayed surgery, 93% still had a fully ruptured ACL, whereas of those who didn't go on to have delayed surgery, only 33% had a fully ruptured ACL. Now, these people were not aware of their healing status. So it suggests that this could be a missing piece of the puzzle when we're trying to predict who was traditionally considered a coper or a non-coper with rehabilitation. Now, this 30% is assuming those who had delayed surgery had a non-heal, which we don't really know. If we exclude those with delayed surgery and look at only those managed with rehabilitation at 2 years, it goes up to 53% with a continuous ACL. And this is what this looks like. This is a participant from the Canoon trial. So at baseline, we can see an ACL rupture. A 3-month MRI, what we'd consider beginning scar formation, partial hyperintensity along the course of the ACL. By 12-month follow-up, a near complete normalisation of scar formation with potential religamentization and a regular course. And then by 2-year follow-up, we can see what we'd consider an ACLOS of 0, so complete normalisation of structure. And that's maintained at 5-year MRI. So you can see this continuum of healing for this individual participant. So our main finding here was that those with a continuous ACL at 2 years reported better outcomes than those with a discontinuous ACL at 2 years, but they also reported better outcomes than those randomised to early ACL reconstruction and those who had delayed ACL reconstruction. So when I'm talking about outcomes, I'm talking about sport and recreational function and quality of life assessed with the KOOS. And these are quite large estimates, and the 95% confidence intervals exceed what we consider to be meaningful for this measure, particularly for the sport rec at 2 years. And you can see here that in green, the proportion meeting the patient acceptable symptomatic state or the PASS criteria. And there's a higher proportion in those with a continuous ACL compared to the other groups. And no one had met the criteria for treatment failure, which is doing really poorly on these KOOS subscales, which you can see in orange. So I'm involved in another study within the narcotics cohort led by Martin England and Joanna Kvist in Sweden. So I mentioned this cohort earlier in terms of ACL re-injury rates. So they also have MRI data, but they have 3D MRI data from 3 months, 6 months, 12 months and 24 months. So we're now looking at the healing in this population. The paper's currently under review, so I won't reveal all the results, but just to give you an idea of the proportion with healing or continuous fibres. So you have those who went on to have ACL reconstruction and those that didn't. So in those that didn't, there's a higher proportion with healing or continuous ligament. So 62% had all fibres in continuity that weren't surgically treated, compared to just 18% who later went on to have surgery. And you can see, again, a variability in the quality of the heel in terms of thickness and whether it's elongated or taut. So the existing evidence suggests actually it looks like an ACL rupture can heal, at least heal in terms of what we're seeing on MRI. But is there anything we can do to maybe help to increase the likelihood of healing? And that's where the cross-bracing protocol comes in. So the initial idea was that of Merv Cross, who was a retired orthopaedic surgeon at the time. And the idea was that early mobilisation, such that occurs with rehabilitation, could actually inhibit a bridge of connective tissue forming across the ligament and subsequent healing. So just like you'd manage a fractured bone by reducing the fracture and immobilising in a cast, the same orthopaedic principle was applied to the ACL. So at 90 degrees of knee flexion and greater is when the two ends of the ACL are in closest proximity to one another. So the idea was, if we immobilise the knee in 90 degrees flexion for some time, that this could help to facilitate healing. So the cross-bracing protocol involves immobilising the knee in a knee brace for 4 weeks, 24/7 a day, at 90 degrees flexion. And then at weekly increments, the knee range is increased within the brace, allowing 60 to 90 degrees, 45 to 90, 30 to 120, and so on, until full range of motion at 10 weeks, and the brace is removed at 12 weeks. Now, these people aren't inactive in the brace. They're performing high, intense, physio-supervised rehab the entire time, including whilst braced at 90 degrees. So there's people doing wall squats, they're doing single leg bridges at 90 degrees, neuromuscular e-stims, isometric quads hamstring exercises. So I think it's really important to emphasise that they're very active. And the other thing that's important to emphasise is DVT prophylactics. So these people are taking DVT prophylactics, and that's really important for safety. Yeah, so here you see some people undertaking rehab in the brace. Yep, so the paper published last year in BJSM reported the outcomes from the first 80 consecutive patients treated with this approach. So everyone that was treated consented for their data to be used, so there's no one that was sort of lost to follow up. So using that same criteria that we used in the Canoon trial, so a 0 to 2, we can see that 90% had a continuous ACL on MRI at 3 months after injury. So this is at the point at which the brace came off. This was largely maintained 6 months, although 4 people had progressed to a normal appearance ACL by 6 months. And here you can see the baseline characteristics of participants, this time split between, so a grade 1 is a thick, taut ACL, and a grade 2 or 3 is thin or elongated or still ruptured. So we'd say a grade 1 is a more ideal heel. Now, something that appears interesting is the difference in the nature of the ACL rupture. So here, for example, you can see who had the femoral origin of the ACL intact compared to partially avulsed. So of those with a thick and taut heel, 83% had that femoral origin intact compared to just 8% with a less ideal heel. And similarly, the degree with displacement, so whether the distal remnant was flipped or dislocated and sitting outside the intercondylar notch, appeared to be associated with whether they had a grade 1 or a 2 and 3 heel. And what about outcomes? So here you see self-reported knee function on the Lisham scale and quality of life on the ACL qual reported at 12-month follow-up. And you can see that this was better in those with a thick and taut heel. But we do need to be a little careful because the grade 2 and 3 also are reporting scores which are similar to what we normally see after ACL surgery. So a Lisham scale score of 94 out of 100 is still in the excellent range. So everyone had a normal Lockman's test with a grade 1 heel at 3 months, and 92% had returned to sport by 12-month follow-up. In terms of the ACL re-rupture, which is a really important outcome, the 4 re-ruptures in those with a thick and taut heel, 2 of them, one fell off a bike going down a hill, a push bike, one was a high-speed skiing accident, and the other 2 had returned to sport early and was a rugby tackle or an AFL football tackling injury. And here you see MRIs from 2 participants that underwent the bracing protocol, ACL rupture at baseline, and a normalised ACL by 6-month follow-up. So I supervised a master's student, Micah, who's from University of Amsterdam, actually, and she had gone through the bracing protocol herself for an ACL rupture and had previously had a reconstruction on her other knee. So we now have over 100 people actually who have a healed ACL in one knee and a graft in the other. And I think that's such a unique and interesting group to learn from, both about how their knee functions and feels now, but also how the 2 treatment strategies compare for them. So she looked at healing outcomes in the next 235 patients, and similarly, a high rate of ACL continuity. So 95% had a continuous ACL at 3 months, 66% with a thick and taut ligament. And she looked at a univariable analysis to try to indicate what factors might be associated with this healing potential. So actually, older age was associated with a better healing potential. A non-contact mechanism of injury was associated with a worse healing potential. Hypermobility, worse healing. Hemarthrosis appears to be able to facilitate the healing response. And as we saw before, partial avulsion and displacement of ACL tissue with quite high odds ratios. So if we look back at that literature review in 1983, William G. Clancy Jr. stated that in the future we hope to be able to discern more accurately which acute ACL ruptures need surgical treatment. I think this is really one of the holy grails in ACL research, and we still don't have this answer. But I do think this new research around ACL healing may prove to be quite effective in terms of helping to predict who will benefit most from surgery and who won't. So I mentioned the femoral origin of being relevant, and whether that's avulsed or intact, displacement of tissue outside the intercondylar notch. The other variable we think is relevant is the distance between the 2 ruptured ends of the ACL, assessed and measured in millimetres, so a greater distance, less likely to reduce through bracing. And then we're also observing a sign which we're calling involution. Similar to a non-union heel or a bony non-union, sometimes the ACL is retracted and rounded and capped over. So we think for these people it's too late to benefit from something like the brace, and surgeries are likely to be beneficial. So where are we at with this research now? I think the numbers just now exceeded 900 that have been managed with the bracing protocol that we have data on. We're performing a predictive model to understand actual predictors of healing. We're developing an MRI classification criteria related to ACL healing potential. We've conducted qualitative interviews and we're performing now a multi-centre RCT. So I'll touch on that in a moment. So the findings from our qualitative study, in a nutshell, I suppose, or in a quick summary, was that it is really challenging to be braced at 90 degrees for 4 weeks. Psychologically challenging, physically challenging. So social support was really important during this initial phase. But then once the weekly brace adjustments were occurring, people mentally are coping much better. And then the main finding was that afterwards, they were very grateful to have had this treatment. Their outcomes typically exceeded any expectations and they would go through the treatment again. And indeed, several people have. So some of those who have gone on to re-rupture have opted to go through the brace a second time and have healed a second time. We've also had some that have gone on and torn their graft in their other knee and wanted to just experiment to see if the brace would work for their graft and have experienced graft healing as well with the bracing protocol, which I didn't think was possible, but apparently it may be. So here you see some participant quotes of people that have been through the bracing protocol. So for people, they often describe it as being as if it was never injured. And that's a common experience. So Micah, that master's student, she'll say, look, her ACL graft feels 90%, never felt 100, but she's still playing high-level hockey now. But her braced knee feels like it was never injured. It feels 100%. And that's kind of a common experience amongst participants. So as for the RCT, we've received funding from the government in Australia to perform a large multi-city RCT comparing the bracing protocol with early ACL reconstruction. So the primary aim is to determine whether this bracing protocol results in better KOOS-4 scores, so knee function, quality of life, pain, symptoms, at 18 months compared to early surgery. Secondary aims to look at the secondary outcomes, and there's a number of them there, including graft re-rupture and graft rates, knee instability, adverse events, fear of re-injury, satisfaction with knee function, return to sport rates, quality of life, to compare these between groups at 6, 12 and 18 months follow-up, as well as to perform a comprehensive cost-effectiveness analysis to see if the cross-bracing protocol is more cost-effective than early ACL reconstruction. So it's a parallel two-group multi-centre comparative effectiveness superiority RCT. Good luck translating that one. So 180 people will be recruited from Melbourne, Sydney, Gold Coast, Brisbane and Perth. We've got a lot of eligibility criteria, but some of the key ones: age 16 to 40, MRI confirmed ACL rupture, and they have to be able to complete the baseline questionnaire within 6 days of injury. So the bracing protocol we're not using on people more than 3 weeks after acute ACL rupture. We think it's something that's beneficial when there's still an acute inflammatory response. And they need to be at least moderately active. And the reason here is because our trial surgeons said, well, I wouldn't perform surgery on someone that's not playing sport, so they shouldn't be in the trial. Even though a lot of these people are receiving surgery in the community, the surgeons in our trial are more balanced, I suppose. So this is the bracing protocol CBP group treatment. So we'll be funding weekly consults up to week 14, and then monthly consults up to 12 months. And then in the early surgery, everyone will undergo surgery within 8 weeks of enrolling into the study, with fortnightly consults and then monthly consults. So the physios will undergo training to deliver high-quality rehab to people in both treatment groups. All right, so to sum up, I just want to go back to these misconceptions when it comes to ACL rupture. So we've now talked about each of these, and I think this could be an hour lecture in itself, just speaking about all the misconceptions out there when it comes to ACL treatment. But why is that? First of all, we need to be aware that the majority of information on the internet is inaccurate. So there's studies showing this, but you only need to Google yourself to figure that out. So let's look on the AAOS website. So this is a pretty important body tasked with providing education and management services for both surgeons and allied health professionals. So you can see that first sentence, complete ACL tears have a much less positive outcome without surgery. So it's not supported by the evidence. And then non-surgical treatment, is likely to be successful or may be recommended if it's a partial tear, which is redundant because the heading's complete ACL tears up the top. With complete tears who don't experience symptoms of instability during low demand sports and are willing to give up high demand sports, and in people who do light manual work or live sedentary inactive lifestyles. So I don't know how many people with ACL rupture you know who live inactive sedentary lifestyles, but it's not many. And the main thing people prioritise is returning to sport. So it isn't painting a very good picture for people with ACL rupture. And the last sentence, many people who choose not to have surgery suffer an injury to another part of the knee due to instability. Perhaps some do, but it's no different to those who do after surgery, and that's not mentioned at all on the website. Here's another website. This is a academic group of surgeons based in the US. Possible downsides of no surgery. Without surgery, your ACL will remain torn. The knee might heal, as in the swelling and pain will stop, but a torn ACL does not reattach or heal itself. And this was updated late in 2023, so we had released our research in this area before this was put on the website. What can you do without ACL surgery? Well, you can go up and down stairs, get in and out of a car, ride a bike, jog but in a straight line, and maybe have minimal discomfort. Again, not a very appetising picture. And they finished by saying there's no way to accurately predict which are among the tiny minority of knees that can return to more aggressive sports and activities without ACL surgery. Again, reminding you of our meta-analysis of no difference in return to sport rates between the groups. But it isn't just websites. So this is a Panther Symposium ACL treatment consensus, an expert consensus where experts get together and come up with some recommendations for ACL management. And some of them are definitely evidence-based, but these three in particular are active patients wishing to return to jumping, cutting and pivoting sports. Surgery is the preferred option. In those who do return to sports without surgery, places the knee at risk of secondary injury, again without any mention of risk of injury in those surgically managed. And in active patients wishing to return to straight plain activities, then non-operative treatment is an option. I don't think that needs an explanation, but if we look at the methods for this particular consensus statement, surprisingly, they only looked at the literature after the consensus statements had been drafted, voted on, agreed upon, and the paper was drafted. Then they looked for supporting literature for those statements. So there was no consideration of the evidence prior to the paper being drafted. So perhaps not surprisingly then, so for this statement, the only supportive evidence that they had found was a retrospective study of 19 athletes who did not have surgery between 1963 and 1965. If you're aware of just how much literature there is in this field, I find it quite amusing that this is the supporting evidence that was found for this statement. I'm probably running out of time, no idea how I'm going, but we've performed an Australia-wide mixed methods study to understand current practice for ACL treatment in Australia. So we recruited 766 adults who've had ACL management and 246 physios, and we also interviewed both and performed mixed methods analyses. I don't have time to go into these studies in detail today. They're under review, so they should be published soon. But the key take-homes is most patients received advice from healthcare professionals that is not supported by the evidence. So here you see in red the proportion of each health profession that told patients ACL surgery was the best treatment option for them. 65% of physios, 87% of surgeons, 68% of GPs. And these were the main qualitative themes. There was some discussion of the role of the GP. So one of the themes here when it comes to ACL injury was that they perceived it only for referrals. They didn't want to know about management advice because they didn't perceive this to be in the GP's realm. Healthcare professionals downplayed both the risks and impacts of surgery. A number of people weren't aware of any risks of surgery or any potential downsides, whereas they were told a lot of downsides when it came to non-surgical management. They often felt surgeon consults were rushed. They felt poorly informed. They said they spent longer in the wait room than they did with the surgeon. They didn't have a time to ask questions and to find out the information they were looking for. And the majority of surgeons promoted surgery as either the best or in many cases the only option. So I think the paper's quite interesting because we show all the quotes of people actually telling you what they were told by their surgeons and their physios, and I think it's quite striking. And when it comes to physios, it was a bit more mixed, more 50-50. So they were either told they have to have surgery, whereas others were told, actually, you don't have to, and there is another option for you. In regards to the physio survey, one of the key findings was that physios' beliefs did not necessarily align with the information they gave to patients. So here, the physios, 60% of them said they agreed that outcomes are similar on average between surgery and rehab only. But when asked what information they provided to patients, only 37% said that they told this to the patients most of the time or always. So despite saying they have this knowledge, they're not passing it on to their patients. And the qualitative studies provide some clues for why this might be the case. So the themes down there in relation to the surgeons, the referral pathway was really important for these physios. So if they'd already seen a surgeon, in the majority of the cases, the physios didn't even bother to tell them about any other treatment option because they were already booked in for surgery. Some didn't want to wreck their relationship with the surgeon themselves, and they felt that patients give more weight to a surgeon's opinion. They wear a white lab coat. Why would I bother telling them anything different? But they did acknowledge that in a majority of cases, the information was often unbalanced towards surgery. In Australia, our society has a strong belief that surgery is required. You only need to watch, AFL or rugby, and one of the star goes down and the commentator's telling you they're going in for surgery tomorrow. So that filters down at a community level. Other barriers were the uncertain recovery timeline with non-surgical treatment. Most physios still believed that young people and those who played sport needed to have surgery. So this age and sport still being a strong belief. And the knowledge and experience of physios really differed. So the need to upskill physios in the evidence related to ACL treatment. So what are we doing to tackle this? We've developed an online ACL injury treatment decision aid. It's been used by over 10,000 people in the last 6 months, which is good to see that it's getting some use. The aim of this decision aid was to provide an evidence-based tool so that patients could make a treatment decision that aligns with their values and preferences. So we put a lot of work into developing this. This was one of the purposes for the 2 mixed methods study. We then reviewed all systematic reviews and clinical trials in the area. We've done iterative piloting with a range of end users, and we're going to evaluate it in an RCT to see if it changes practice. So there's 5 different steps that the patient can work through on this website. So step 2 is learning about the treatment option and what's expected and what's involved. Step 3 is learning how the outcomes compare. So summarising the evidence for a range of outcomes and then comparing this between treatments. And then step 4 is weighing up the pros and cons. So they can go to the outcomes that matter most to them and then weigh up the pros and cons between the treatments. And finally, to help them arrive at a treatment decision, we have a task where they can rank the outcomes that matter most to them. And they can also print out a summary of where they're at and bring this into their healthcare professional or download the entire decision aid as a PDF. So that QR code will take you to the decision aid, but it's at aclinjurytreatment.com. And we're also working at translating this into a few languages because people have reached out to us that want to translate it, so we might replicate the website in other languages as well. So in summary, the high rate of surgery in Australia is not supported by the best available evidence, which shows similar long-term outcomes for acute ACL injury following surgery or rehab alone. Many people with ACL injury receive advice from healthcare providers that's not evidence-based. And the information provided should be balanced so the patient can make an informed decision that aligns with their values and preferences. And when it comes to ACL healing, the potential for healing the ACL to facilitate better outcomes may be greater than previously considered, and this should feature, at least, in ACL injury treatment discussions. And a novel bracing protocol shows promise in its ability to facilitate healing, and an RCT is underway to compare the bracing protocol with surgery. Thank you.